Hoitonen, 19...
Hoitonen is joint.
I didn't have a TV when I was a kid, you see, so I don't know.
Are you serious?
I didn't have a TV till I was 18.
This is just a little bit of foreplay.
That is basically death. That is death waiting to happen.
No, that's fine. A second I thought you were asking me to arthroscope a rectum. That's a new one on me. Okay, episode 4.
That is an improvement on episode 4.
Can't help it. I keep saying so. I don't know if you've noticed, but we've changed the name of the podcast. Have you noticed?
Oh yeah, I knew that.
I'm not sure you knew what it's called before. So we called it Podcast, which was a suggestion from John McKenna.
Yes.
No one could find it. No one could spell it. Was it an apostrophe? Was there not? So we changed the name to...
See one, do one.
There you go. See one, do one. You're not looking at that.
You got me sweating there.
And the people really struggle with it. People couldn't spell our names. We work very closely with colleagues and academics on the MSc now. MSc in Orthopaedic Trauma Science for 5 years. I consider you a brother from an albino mother. So, without looking, how do you spell actor?
It's AKHTAR.
That is amazing. Honestly, genuinely, I didn't think you'd ever get that. That's very impressive. I can spell bakes without looking. TWA. So
you're almost there. Almost there.
Yeah. So it seems that rather more than the 3 people we thought were going to listen to this podcast have actually listened to it. But rather than kind of fame and riches, it's just created quite a lot of bother for us.
I've had a lot of feedback from, not a huge amount of feedback, but a bit of feedback from people who feel there's too much chat, all a bit self-indulgent. That was the term my wife Chloe used.
So when she accused you of being self-indulgent and looking after yourself, she was referring to the podcast, was she? Just to clarify. So what do you think? So I'm curious to know what people think. Because the fact this is just us talking as we normally do, and it's quite fun for us, for me to chat to you.
Yep.
And we've recorded it and put it in. Yeah, it's a privilege to talk to you. But the fact is, some people just want all the content. So I'm happy for people to come back to us at Twitter. I'm at CashActor. You're at Pete D Bates? Pete Bates. You never use it.
I have no idea what my...
We'll look it up.
Yeah.
It'll be.
No, it's at Pete Bates.
At Pete Bates, but you never ever use it, do you?
No, I hardly ever use it. I should use it.
You should use it. No, people keep messaging you on it.
Yeah. I should totes use it.
Remember I said to you last one, it's okay to talk about my 3 gym memberships, because my wife would never listen to this.
Oh yeah, you're in trouble for that, aren't you?
I got a WhatsApp from her a few days after saying, so 3 gym memberships.
Is that how you and your wife communicate? Is it through WhatsApp?
Yeah, generally ships are passed in the night.
Yeah.
And that way I can at least delete my responses before she gets to read them. But I got this message saying, so 3 gym memberships, sir. Done. And I was absolutely bricking it. I was like, where's this going to go?
Yeah.
Honestly,
you're stuffing down a kebab, like massaging oil into your huge belly.
I almost wish I'd been having an affair so I could have confessed to that instead. I think it'd have been easier. The long and short of it now is I only have 1 gym membership.
Oh, so you cashed them in, okay.
And I have to accept that I'll never have a 6-pack. I kind of worked to the assumption 6 gym memberships is a 6-pack. I've got 1 membership, so 1 pack.
You're working yourself up to that.
Yeah, I'm well on course for that. So loose lips, 6 ships. So we better be careful here. Yeah. I doubt she'll ever listen again. It's a shame because I really wanted just to say that the thought of it just makes me smile. The last episode we've ended on the EastEnders duffs. Did you hear those? The duffs is what they call the dum.
Oh yes, got it. Yeah.
And you tease us with pelvic binders.
Yeah.
And I need closure.
You need closure. Yes, you do. The thing about binders is that every time I give a talk about pelvic fractures, all anybody wants to talk about is binders. That all the questions that come out of the audience, every single one, is about binders. It's really weird how people get so stewed up about the one thing around which we have very little evidence.
Is there any evidence for binders?
There is a bit. There is some evidence for binders. It's really muddy because, of course,
dirty.
It's dirty because it's all retrospective. All of the physiological stuff, at least, like, is it good for patients? Does it save lives? All of that is retrospective. And yes, if you've got a trauma patient and you put a binder on, the retrospective evidence does show that it increases your blood pressure, your arterial blood pressure, significantly compared with if you don't put one on. So there is some physiological evidence in active trauma patients, but most of it has been done in vitro, in cadaver labs, and in models, and on living patients with pressure transducers.
So tell the folks at home. I mean, most of them are sure no, but there may be some people who don't. Where should it sit? Because that's the biggest cock-up, is binders being put on in the wrong place.
Agreed. And I think there are some things we know about binders, and we're pretty confident we know them. And one of those things, of course, is that they should sit over. They should be centered upon your greater trochanter. Centered upon your greater trochanter. Now, yeah. When you lying down flat, your distal radius sits. Is it your distal radius? It's right there. Look, go on, you stand up. Yeah. Where's your GT? Because when a patient's lying in the road, yes. where exactly does it go on? Yeah. Or lying in the resus bay, where does it sit? Actually, it's centered about approximately where your distal radius sits. Yeah. But basically, it should be centered upon that point. That is where it's got the best mechanical advantage, and that has been demonstrated in multiple studies.
And when you put it on, how tight do you pull it? Because you can,
you can absolutely jack it. If you put your foot on the patient and you get like a couple of people, that nursery rhyme about the giant turnip, where all these
there's no such nursery rhyme.
No, there is. Basically, there's this giant turnip, and someone tries to pull it up, but it's a magic turnip. It gets stuck to the turnip. Right. So then someone comes trying to help them. They try and pull them, and they get stuck to them, and the next person comes to help, and they get stuck to them.
I don't think this nursery rhyme exists.
But you can do that with a binder. You can have 6 people all pulling.
I think you're talking about the human centipede here. It's not. But so listen, you know how you can pull anything. Look, I can see your belt's pretty tight there.
Yeah. How tight do you go? How tight do you go? And the answer is all of the proprietary pelvic binders nowadays have a little click on them. Yeah. So you tighten, and they go click. And when you got the click, that's the measured tightness for that binder. How did they work out? How did they know?
Yeah. Tell me this. What's the binder doing?
Exactly. What is a binder doing? And I think how do binders actually work? And we think as a community, there are 3 things that a binder does. Number 1, it holds the bones of your pelvis still. It holds things still.
So you can clot.
So when you roll around, move in and out of CT, get transferred on and off your spinal board, the pelvic bones don't move around much, and therefore any clot that has already been formed stays where it is. Number 1. Number 2, they are well demonstrated to close down open fracture, open book type pelvises. So if you've got a splayed open SI joint, you've got an LC3, you've got a pelvic fracture which is displaced, it will reduce that displacement. That is well demonstrated, and actually there are now reasonable, admittedly in vitro studies showing that a binder is actually more effective in reducing SI joints in an open pelvis than an X-fix is, amazingly.
So some people get excited about, well, it's a vertical shear, do you really want to put a binder on that?
Yeah.
What do you say to that?
So I'll come to that just a sec, because that raises a really interesting point. But the third thing says holding the bone still, closing down, reducing exposed pelvis, and shutting down venous bleeding. This is so
not arterial, which is the classic mistake.
Okay, so in the lateral compression, what you're effectively doing is you're squeezing the cancellous surface of the sacrum together. So that's reducing down that cancellous bleeding. I'm going to stop there. Actually, I think we need to be clear on where we think bleeding comes from when you've sustained a major pelvic fracture. Where does the bleeding actually come from? Because you could talk about what a binder does, but actually where the bleeding is coming from is kind of the primary question. Yeah. So where is the bleeding coming from? And it goes back to this guy, this dude back in the 70s, and he was...
Huitinen, 1973.
Smoking
and drugs.
Journal of Surgery. And he basically... he basically he picked up, it's a pretty macabre thing. He basically picked up a load of people who died of pelvic fractures, who died from like the sustained pelvic fracture, and then they died of sanguinary hemorrhage, and he opened up their pelvis and he found out what they had died from, what vessel was bleeding out. And his conclusion was that the vast majority of people who died of exsanguinary pelvic bleeding died of venous bleeding. It's like around about the 85-90% mark were venous. And the rest is going to be things like, rest is arterial. There's also, of course, bleeding from cancellous surfaces, bony surfaces. So those are your three sources of bleeding. Cancellous surfaces, arterial, venous. Venous being the big player. When you think about cancellous surface, okay, well, what cancellous surface? There's the cancellous surface, so like an APC fracture, like an open book, it tends to open up at the symphysis and the sacroiliac joint, right? There's no cancellous surface there. So the ones that have an exposed cancellous surface are vertical shear fractures, where you've gone up through the sacrum and now you do have a big area of cancellous bone exposed, and that can bleed freely at close to, not at, but close to arterial pressure.
So are we saying we should put pelvic binder on any presumed pelvic fracture?
Yes, we are. We're saying that it is safe. The literature has been around, has been reporting complications of binders for a long time now, and all of the complications are around soft tissue injury. They tend to be skin or gluteal necrosis. It is not around because they've been left on too long. The complications are not around visceral injury caused by a binder. Not even case reports of that.
Because I know you're a huge fan of them, and you're obviously leading on our pelvis here. And the fact is that here we don't X-fix at all. And the general surgeons, if they need to pack a pelvis, the trauma surgeons, our dear colleagues, they will pack it against a binder.
That's right. They're
not against an
That's
X-fix.
right. And the thing where the top of a binder sits, it sits about your suprapubic region. You can easily do a laparotomy and pelvic packing above it without even desterilising.
It makes it slightly easier. I mean, I worked in a place where they would do pelvic X-fixes regularly, and the fact is you're then going to make it quite low at the front so it doesn't interfere. So actually it may interfere less.
Yeah.
And I think it just simplifies things, doesn't it?
Yeah. But I think the killer take-home message about binders in terms of how they work is that in vitro, like cadaveric studies have shown, so Pallister and Parker did this study, they published in Injury 2017. They did a nice study. They put like pressure sensors inside cadaveric pelvises, and then they made up an unstable pelvic fracture and they stuck a binder on, and they looked at the increase in pressure. When you put a binder on an injured pelvis, the pressure inside, if you pull it to the right tension, the pressure goes up to around about 15 or 20 millimeters of mercury. Goes up to about 15, but somewhere between 15 and 25 millimeters, depending on how you do it, whether you augment it with bolsters on the side, whether you strap their thighs together as well. There's some variations, but basically you increase the pressure to around 15 to 20, 25.
And so I'm assuming that's to get you above venous pressure.
So, what is central venous pressure? What's your central venous pressure right now? Central venous pressure in a normal healthy adult is about 10 to 12. In a trauma patient, it's below 10. It's in a shocked patient, it's about like 4.
Yeah.
So what the pelvic binder is doing is it is turning off venous bleeding. Dramatic pause. A pelvic binder is shown to achieve pressures inside the pelvis that exceed central venous pressure, and therefore is turning off the vast majority of pelvic bleeding. And therefore, that's why we think they work. That's probably the primary reason we think they work. Number one, they stabilise the clot. Number two, they jam together cancellous surfaces which are active sources of bleeding, so it squeezes them together in the lateral compression situation or vertical shear. And number three, it causes increase in intrapelvic pressure that exceeds central venous pressure and therefore shuts that down. So what you're left with, the patients you're left with who are bleeding, are either bleeding from somewhere else, their femur, their abdomen, their spleen, whatever it is, or they are bleeding from arteries. So you asked the question around vertical shear, because if you imagine in your mind you've got a vertical shear injury, let's say someone's fallen out of a building or whatever, and one side of their hemipelvis is up, is vertically sheared. And you make the point that if you just put a binder on that, then you've got a bit of a mismatch, haven't you? It's like you're trying to fit a jigsaw puzzle back together again, but the pieces aren't aligned. And you're absolutely right.
I usually am.
No, I know. You have a propensity for being right. I was at a lecture myself the other day at a guy called Archdeacon. He's a big US trauma surgeon, very well known.
That's his real name, Archdeacon.
Archdeacon, that's his name. No, he's a good guy. He's one of those broadest men I've ever met. He's so wide.
Wasn't Archdeacon the baddie in Airwolf or something? Wasn't there a guy with one eye?
No, I didn't have a TV when I was a kid, you see, so I don't know.
Are you serious?
I didn't have a TV till I was 18 years old. Yeah, my dad was a bit of a Victorian dad, and he was a bit stern and a bit old-fashioned. He still is. He still doesn't watch TV really, unless it's the rugby.
I'm finding out so much about you just doing this podcast. It's quite open, and it's all making sense. So you were locked in a cellar.
No. There was no
24
we didn't have
hours
a cellar.
a day.
We would have been, but we didn't have a cellar.
Okay.
We were forced to wear Victorian clothes and Hessian shirts
and climb the chimney. You boy.
Yeah. So no TV till I was 18.
I interrupted. You're talking about
Archdeacon. I saw he was giving a lecture up in the Edinburgh Trauma Symposium, and he said so people come in with their binders on, maybe, but if they've got a vertical shear, what you can do is you can loosen off the binder, apply traction to the leg, and then reapply your binder. So almost reducing the fracture and then reapplying the binder. And that was something that really resonated with me, and I think that's something that I would do nowadays. Although
I can fully see the sense in that, and that makes absolute sense. At the roadside, you put it on no matter what. In A&E, you put it on. The fact is, really, if you're doing a pelvic manipulation, as it were, that's something that is being done by pelvic surgeons in a major trauma centre, rather than your average orthopaedic surgeon in a trauma unit. Exactly right.
So this is a pelvic specialist going down to ED, interpreting the CT and say, look, it's vertically sheared on the left side. I'm going to pull on this left. I'm going to loosen off that binder just a little bit, pull down, reapply it. That may dislodge a clot, but what it will also do is it will reapproximate those cancellous surfaces more anatomically. Yeah. And I think in the situation of someone who is still actively bleeding, that's a thing to do.
Okay.
In a patient where you're just doing it to make the X-ray look better, that doesn't make sense.
That's usually the reason I intervene.
Make X-rays look better. So just because you're a vertical shear doesn't mean you need to do that.
Okay.
But if you have a displaced pelvic fracture at the back and you are wanting, and they're still actively bleeding, you're thinking about the next thing to do, that would be a thing to do.
Every day's a school day. The other thing is that we talk about binders hiding things, and you can get groin perineal lacerations, and I think sometimes people don't understand the implication of that and just how significant that can be.
Yeah, and so you have quoted in the literature, pretty old literature, I have to say, open pelvic fractures carry a 50% mortality, and I'm not really sure where that number comes from. I've looked for that paper. I'm not quite sure where that comes from, because are these all open pelvic fractures, and otherwise ones that don't even make it to hospital? In which case, maybe that's true. But of the ones that come into hospital, there are open pelvic fractures and there are open pelvic fractures. That's a bit of a lame thing to say, but there are ones where the wound associated with the open pelvic fracture isn't actually that bad, and there are wounds that are absolutely devastating. And the thing that really sits between those two, the thing that defines those two, is a rectal or a perirectal injury. So if you've got a wound in your groin that is literally where the bones have burst out through the skin, that's not actually very, very different from an open tibial fracture or an open femur fracture. The bone has burst out. Yes, it's a horrible injury, and yes, there is a pelvic hematoma which may get secondarily infected by skin organisms. So it's not a thing to take lightly, but at the same time, it requires the usual treatment that we give to other open fractures.
As per the post guidelines. But the ones that I think you're going to refer to are the ones where there's bowel injury.
Exactly. So it may look like a rather banal, like perineal wound or like a groin wound. It's like, it doesn't look like very much, but actually there is a perirectal injury as well, where basically you've got shit in your intrapelvic space. Literally.
Yeah.
So you've opened, the rectum's opened. You've got, albeit a small amount, you've got feces in around all that pelvic hematoma. That is basically death. That is death waiting to happen. It doesn't happen straight away though. It happens at day 5. So if you don't discover that opening, that rectal injury, until day 5, when the patient starts getting sick, you've lost it. It's gone. The patient then dies. You cannot bring it back. You can do any amount of surgery, but they get so hideously septic that you've missed the boat.
And these are young, fit people.
Exactly.
And so that's why it's so vitally paramount that when the binder comes off, you have a full secondary survey, and in particular, you're consciously looking for these things.
Exactly. You're very much in like secondary or tertiary survey mode when you take that binder off. Very easy to take them off and go, okay, all right, and then you move them with the wardrobe around. You've got to like open up the legs, lift up the bull bag, have a really fucking good rummage around his perineum. And really feel like you've said, I have now, you can stand there with your hands in the air and go, I have excluded a perirectal injury. Or you say, actually, you know what? I think we ought to get the general surgeons to see the patient and do some kind of sigmoidoscopy.
And these injuries can be a 1 centimeter nick in the skin, and you think, well, what's the big deal?
That's right.
But the fact is that this could be a killer.
Exactly, it could be a killer,
hidden killer.
Exactly. So, and to be fair, often perirectal injuries do show up on the CT scan. So sometimes the radiologist will pick up that there's some kind of bowel injury, and that's fair enough. But not always. Yeah. And the only thing that really, you've basically got to get the patient up into theatre, into a lithostomy position, and have a proper look and put a scope up and get your general surgeons to do that. And those are the ones where a defunction becomes a thing you've absolutely got to do.
No, that's fine. For a second, I thought you were asking me to arthroscope a rectum. That's a new one on me. I'm not sure what the code is for that.
Come on, man up.
I'm not sure what the code is for that. But
just
the one thing I would say, so our general surgeon colleagues are skilled. They do great work. What should we say to them? Because they may not be familiar with this. There may be general surgeons have gone 10 years of training and have never seen an open pelvic fracture.
Yeah, exactly,
right?
exactly.
So what do we say to them? What are we asking of them?
We are asking of them to have an index of suspicion that there may be a rectal injury. And you're looking at them and saying, I want you to exclude a rectal injury. I know you've seen the CT and you're happy that it doesn't look like one, but I want you to exclude it. And in the presence of open wounds around the perineum and the perianal region, they absolutely need to do that.
So we're talking patients up in stirrups, legs akimbo.
That's it.
And rigid sigmoidoscopy?
Rigid usually does it because the injury is usually quite low down. So yes, it's in that tethered part of the rectum. So the sigmoid's quite floppy, isn't it?
Yeah.
And it's like blah, 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 blah. So it's less likely to get damaged because it kind of moves out of the way. But the rectum where it where when you need a dump and you suddenly you feel it coming on, that's when it all empties out into that hopper, if you like.
Yeah, no, I'm feeling that right now.
That's the bit that is tethered down, stuck onto your coccyx.
Yeah.
That is the bit that is vulnerable to injury.
So
So rigid will get there is the answer.
So as an SHO, I used to do lots of rigid sigmoidoscopies in clinic.
Right, there you go.
I worked for David Selly.
Right.
David Selly, the story. The sad thing, just a quick aside, quite honestly, one of the most meticulous and caring and skilled clinicians I've ever met in any specialty. He was a gentleman. I remember once telling a patient, I remember him finding a incarcerated frontal hernia that had been missed by everyone.
Right.
Took the patient there to save them. I remember a time he told a patient they're dying of cancer, first time diagnosis. The patient burst into tears, thanked him, hugged him, and was like, I'm so grateful, thank you. And was like, wow, this guy, just immense. And what he went through was just horrible. But I used to do rigid sigmoidoscopies in clinic, and he taught me how to do them. And you do this thing where you've got the patient on the left lateral position, you put this massive tube up there, you inflate the air.
Yeah, the air thing always used to terrify me because it's like
poof, poof. And then the thing I learned after a while is you do that, and you're looking down the tube, and then you jump out of the way because that air's coming back at you.
Yeah,
with interest. So it's like poof, and you're kind of like ducking as if you're kind of trains going past you at high speed.
Yeah,
it was. So they do that, and then you ask, and then if they find an injury, they're going to do a laparotomy. They're going to do a defunctioning colostomy.
If there's a rectal injury, yes. If it's just a skin injury, actually what you can do is just wash it out and close it up. So primary closure of open pelvic fractures is okay. You can do that. So they can be actually not massively serious any more than an open femur fracture is serious. It's just that you've got to exclude that deeper injury, because if you don't, that is death waiting to happen. And they're really rare, but when they happen and they catch you out, you cannot catch back up again.
And on that positive note, the downside of binders, as far as I'm aware, is obviously you get necrosis of skin and soft tissue injuries. Fact is, they can mask stuff, so you can miss things like an open fracture, a rectal injury, something like that. So you can miss those if you.
For me, that's the big one. So everyone's aware now. People are very aware of not leaving binders on too long. So if you leave them on too long, particularly if they're fully jacked, so that's the other evidence we have out there, is that if you pull a pelvic binder to tension, what ends up happening is you exceed the pressure that the skin can survive underneath, particularly over bony prominences like your GT and your iliac crest. So it's not over your GT. So if you leave a binder on at proper tension, you will necrose the skin eventually. Skin's pretty robust stuff, but not forever. So the British guidelines, the BOSE guidelines are for them to be taken off within 24 hours, and that's I totally agree with you.
That's the most common question that gets asked in medicine about binders.
But how long do you leave them
all
on
specialties? How long do you leave them on for? And if a patient's been unstable, you come in at 24 hours, are you taking that binder off no matter what?
Okay.
You're an ITU, HDU.
Right. So let's start in ED. You're in ED and the patient comes in with a horrible pelvic fracture, but they are hemodynamically stable. You can look to be taking that binder off in the emergency department, and I would encourage people to do that, because they were never unstable in the first place.
But could it not be that they've clotted and that the binder's held them stable?
Right. So once you've demonstrated their clotting has been restored, so you've got a rotem and it's normal, or you've got an INR and it's normal, then it's reasonable to take that binder off in the emergency department. Patients initially unstable and then they stabilise. That binder can come off once you again have demonstrated that their clotting has returned to normal, because they've clotted off and they've been stable for a few hours. You can now take that binder off. In practice, what that comes out as is that you're seeing them the following morning. They came in like 5 o'clock in the evening, you see them the following morning, they've still got their binder on, they've been stable now for 6 hours or so, and then you take the binder off on the post-take wardrobe. That's where I tend to find myself when doing rounds of that sort. There's the third one, which is really unusual. This is the patient who was absolutely in extremis. They've had multiple surgeries, they are shocked as hell, they came in a terrible state, and they were lucky to survive, and you've basically managed to save their life, but they are still really, really sketchy and a little bit hypotensive, and they're on, the ITU guys are really worried about them. In that situation, you don't lose anything by leaving the binder on, but you can just tuck your fingers around the side and make sure that the pressure's okay, and maybe loosen it off a little bit, so it's still having some stabilising effect, but it's not necrosing the skin.
3 downsides to binders: pressure on the skin, cover stuff up, and you can hide APC injuries.
Hiding APC injuries, the answer to that is you've got to X-ray out a binder. So if you've got a major trauma patient who may have sustained a pelvic injury, you get a CT scan and X-ray, which look absolutely fine. You still do an X-ray out a binder, because their pelvis can just flop open.
So just to clarify, what I mean when I say masking APC injuries is an open book that's been closed with a binder, and then you take it off. That's what I mean. An open book, you can miss that.
You can miss it. You really can miss it. That's genuinely a thing. And going back to your thing about masking, like covering stuff up, we're out of sight, out of mind creatures. So when you don't see something, you don't believe it exists. But you can have horrible groin lacerations, you can have perineal injuries, you can have rectal tears, hiding under a binder. But because the binder's on, everyone's like, oh well, the pelvis is sorted, we don't have to worry about that. So whenever you're taking off a binder, my final point, take-home message will be, whenever you're taking a binder off, you're in secondary survey mode. You're in, I'm taking this binder off, I'm going to lift up this guy's ball bag, I'm going to have a look underneath, I'm going to look at his perineum, I'm going to make sure I'm happy there's not something else going on here.
What could possibly go wrong? Exactly. Thanks so much, Pete. See you next Tuesday.
See you next Tuesday.
copyright for some.